All right, welcome to part two of drugs affecting the cardiovascular system. Hmm, that's weird. Okay, hold on. All right, well, next up, we'll talk about a totally different organ, and that would be the pancreas. And that particular disorder associated with the pancreas would be diabetes. The pancreas is really like two organs in one. Next week, we'll learn about the exocrine functions. Those are the enzymes the pancreas makes to help you digest that piece of pizza you just had. And there are diseases associated with that part of the pancreas, like pancreatitis and exocrine pancreatic insufficiency. But today we're talking about the endocrine functions. The pancreas makes insulin and it makes glucagon, and they do opposite things. We don't really care that much about glucagon. Um, um, there aren't really any diseases or not very many common diseases involving glucagon, but there are many times you'll see problems with insulin. So before we talk about diabetes, let's just review function of the pancreas, right? So you've got these fuels in your body that you can use. Some are sugars and some are fats, right? Both of them can be used as fuel. And by sugar, we mean glucose. Most tissues in your body can use either glucose or fats as protein, right? Your skeletal muscle, your smooth muscle, um, liver, skin, whatever, right? But there is one part of your body that cannot use fats. It can only use glucose. Yes, that would be your nervous system, and in particular, your brain. Cannot use fat as an energy source. It can only use glucose, and it has very high um, demands for glucose. So diabetes mellitus mostly involves a problem with the metabolism of glucose, and we'll focus on glucose, therefore. Now, where does glucose come from? Well, it comes from any old carbohydrate you eat. It could be that piece of bread, potatoes, pasta, a candy bar, whatever. It all gets broken down into glucose. And you'll see next week, even plants have glucose. We just can't break them down. But they're all just these little simple sugars. And every tissue in your body needs glucose. And the hormone insulin is what allows the tissues to absorb glucose. So insulin gets produced by the pancreas as part of this way to help your body utilize sugar. Here's the pancreas. You can't really see them, but you have to imagine all these little cells that make insulin. They're called beta cells, and they're making insulin, this little yellow ball here. And then there's sugar, these little sugar cubes. And here, these could be what? It could be a liver cell, a brain cell, a spleen cell, whatever you want, right? These are all important little cells here. And then insulin locks onto this receptor, and that opens a channel that then allows glucose in. Glucose is it cannot just diffuse across the cell membrane. It's hydrophilic. It needs to travel through some sort of a channel. And you can see these cells, the glucose cannot enter because the insulin has not unlocked the channel yet. So with diabetes mellitus, before we say anything else, there's really common misconceptions that I hear, and I used to make them myself before I became a veterinarian. So one is people will think, oh, that their pet has diabetes mellitus because they keep gaining weight. The opposite is true. Diabetes mellitus, those patients are losing weight. Another thing people will think that diabetes mellitus is causes low blood sugar, and it's the opposite. It causes high blood sugar. The treatment can cause low blood sugar, right? The insulin treatment, but the disease itself, blood sugar is sky high. There's two different kinds of diabetes, and I think they're not too difficult to tell apart, but just let me know if you get confused. So one's called type 1 diabetes, and one is called type 2 diabetes. So type 1 is where the pancreas is just failing to make insulin. There's just not enough of those beta cells. And so there's just a lack of insulin. So there's this glucose. It wants to go in the cell, but where's the insulin? It's not there. So this is called type 1 or insulin-dependent diabetes. Insulin-dependent means this patient is going to depend on insulin. They must have insulin to get better or to be treated. This is almost exclusively in dogs. You might see it in cats, but this is mostly a dog disease. And it's because maybe the dog had pancreatitis and that caused damage to the pancreas. In some cases, the dog's immune system has attacked the pancreas. With type 2 diabetes, there actually might be enough insulin. The problem, though, is that it just won't bind to the receptor. Something it's like the key won't fit in the lock. So this is called insulin-resistant diabetes. This we see mostly in cats. There's a lot of different factors, but obesity is one factor. Something about a cat being obese, the pancreas might be making insulin, but it just cannot activate the receptor. Now, here's what's always confused me is we treat both of these with insulin. I mean, we treat type 2 by giving the cat insulin, and it works. So I've never totally understood that. But you will see that with type 2 diabetes, something unique is that in some cats, it can go into remission. If they lose weight, if they get more exercise, kind of like in people, the diabetes will go away. Sometimes, not very often, but sometimes. So the pathogenesis and the clinical signs are all about cells that cannot utilize glucose as an energy source. So, for example, these cells, there's all this glucose passing by and they can't get any of it. They are starving for glucose. So what's the effect? Well, your patient is starving. Your patient is going to be constantly hungry, but they can't utilize any of the groceries. So they're polyphagic and they're losing weight. Right? They're eating, they got a great appetite, but they're losing weight. That's one thing. They've got glycosuria, which means glucose in their urine. Well, what effect is that going to have? Water, we've learned, will normally follow salt from the nephron out back into the body, right? That's reabsorption of water sometimes involves salt. Well, that's great, but if there's sugar in the nephron, some of the water is not going to follow sodium, it's going to follow glucose instead. And now you have all this water being osmotically attracted to glucose. What ends up? A lot of pee, polyuria. And then that's going to make the patient drink a lot more. There are other signs that we see. Some of these patients are at risk for developing a urinary tract infection, all that delicious sugar in their pee. Obesity is not really, I mean, I guess it's a symptom, but they're losing weight. Lethargy is not spelled correctly. A couple of unique things that we see in cats. You've heard of people having diabetic neuropathy or diabetic pain. Diabetes can do weird things to nerves and maybe to ligaments. So cats will get this weird, where I don't know if it's the Achilles tendon or what, but they're actually walking on their hock, right? That is not normal, and that's called the plantigrade stance. So that's kind of unique to diabetes. Dogs, something about the sugar in their blood will cause cataracts to form, right? That's where that's the lens in the eye. In your eye, you've got this thing called a lens. It changes shape, it focuses. The whole thing will just turn, it'll change from a see-through protein to this, it looks like ground glass. It can happen overnight. The owner can go to bed and wake up and their dog looks like this. It's irreversible and it's shocking to clients. And a third thing that can happen, and it can happen in a dog or a cat or any of us, is so the body cannot use the glucose, but they need energy. So the body starts to burn fat, right? That's part of that weight loss we talked about. The body is burning fat to produce an alternate energy source. Now, what's the name of this alternate energy source? If you took clinical lab techniques last semester, we talked about it. What's it called, and what are the disadvantages and risks to it? Well, they're called ketones. So when you use up carbohydrates, or when your liver breaks up glycogen, you make glucose. Well, ketones are a different energy source made from fats. And they're actually a pretty good energy source. If you're starving and you're burning fat, thank goodness you got ketones, right? They're a pretty good energy source. Your brain can't use them, but every other cell in your body can use them. In fact, some people, to lose weight, will try to increase the number of ketones in their body. And they'll eat, they just won't eat very many carbs. They'll just eat protein and fat, and their body will start to burn fat because they're not eating enough carbs. The problem, though, with too many ketones is they are acidic. And we also learned last semester, your body does not like your pH to change. Your body regulates your pH very tightly. That's how acidic or alkaline your body is. And these ketones are acidic, and they will create this problem called, it says diabetes ketoacidosis. It should say diabetic ketoacidosis. It's making your patient more acidic. That does terrible things to their enzymes and their proteins. As I said last semester, why does the body care about pH? Because proteins care. Proteins like hemoglobin, albumin, clotting factors, all the enzymes that carry out zillions of biochemical reactions. If the pH changes, they start to change shape and they won't work. It can result in death. So diabetic ketoacidosis is really serious. Okay, back to diabetes. How is it diagnosed? Well, it's pretty straightforward. You've usually got these clinical signs, plus you've got glucose in the urine, that's glycosuria, and you've got an elevated blood glucose. In dogs and cats, it could be above 200, above 250. It can be quite high. How is it treated? Well, in both type 1 and type 2, we're going to use insulin. And by exogenous, I mean we're going to give them insulin. Dietary management can help. In a dog, we actually feed a high fiber diet. And in cats, we actually feed a high protein diet. And we'll be learning more about diabetes next year. What kind of monitoring? Well, like with all these endocrine diseases, we need to tweak the dose. We'll start the patient maybe at kind of a conservative dose, and then we want them to come back to recheck. And I'll talk a little more about what specifically we're doing. Our goals of treatment, again, are to reverse all these signs. Stop losing weight. Stop drinking and peeing so much. If they're vomiting, get them to feel better. And in the cat, sometimes our goal is maybe, if we can, to get the diabetes into remission and it'll never come back. And again, we're going to talk more about client education. We'll talk more. So now there's a few differences. Dogs and cats are not treated the same here. We'll see that remission is not going to be possible in a dog. Also, we see that the drugs work differently. They're not as long lasting in cats compared to dogs. So we have to treat dogs and cats a little differently when they have diabetes. Remember I said the dumbest pancreas is smarter than us. So you're releasing insulin all the time, a little more, a little less. I mean, it's constantly adjusting. Your insulin does not just release, your pancreas does not just release a bunch of insulin at 8 a.m. and 8 p.m. But that's what we do. That's all we can do. We can't have the owner giving insulin, every second of the day. So we have the owner give it in the morning and at night, usually 12 hours apart, subcutaneous. And, this is a big commitment. It's one thing to give your dog or cat a pill, to have to poke them with a needle, every 12 hours for the rest of their life is a big commitment. And so we need to prepare clients. We have to be realistic. We also don't want to scare them off. Many people are willing to do this, but they need to know what they're up against. It would be great if we could talk to April Oberman's cat has diabetes, and it would be great to hear April's thoughts. Maybe April can say something during the discussion this week of what went through her mind when she learned that her cat had diabetes. So again, insulin is how we treat it. There are different kinds of insulin, and this gets a little frustrating because there have been times where just as you get a patient well controlled, you've tweaked their doses a few times, and now things are going well, and suddenly the company says, "Oh, we had to stop production of our insulin. There was some quality control problem." You just got the patient's diabetes controlled, and now you have to switch to a totally different insulin. So it's very frustrating. Some different products will come and go. It's a little frustrating. So we use, and the book is a little confusing. So I'm going to try to present another way of thinking. I've tried to organize these different insulins in a way where it won't just seem like a mishmash. So different insulins are used for different things. Some are for long-term control, some are for emergency treatment, and of course some are used in different species. But certain things won't change, and that'll be kind of our focus here. So what are some of the different kinds? We classify them by their duration of activity. Some are short acting, some are intermediate acting, some are long acting, and they can also be categorized by how they were made. Some are actually made from pork, and others are made using genetic engineering. Now, I put Stewie Griffin down here in the corner just to remind me that I don't really find, especially the pork versus genetically engineered, I don't really find that very helpful. And so I'm going to try to clarify a few things the book says, but I'll show you a couple things here. So here's Vetselin. This is this porcine insulin zinc suspension, also called Vetselin, right? So this one is actually made from pork, from pigs, I should say. It's not made from pork. It's made, I guess, from the pancreas of pigs. And then there's this one called Glargine. Its trade name is Lantus. This one is not from a pig. It's made using recombinant DNA, fancy biotechnology. Okay, they're both really good products. Okay, Here's how I thought would be a helpful way to think about the different insulins. We're going to look at three different scenarios. One is an emergency situation. This patient is in diabetic ketoacidosis. Their pH is too acidic. They're, they are they are vomiting. They're dehydrated. They are not eating. Right, that's bad. The diabetic who's not eating is pretty serious. And of course, they still have diabetes. Right, they're dumping sugar into their urine. Okay, so emergency. Here's a patient who, again, and we'd say was just diagnosed today. All three of these patients were just diagnosed today. This patient has diabetes. He's still eating, but when you do the blood work and the urine, you find there are ketones in his pee. The owner says he's acting a little bit lethargic. So he's okay, he's stable, but you're worried that he could be heading to being like this patient. And then our third patient is not having he's got diabetes, but he's eating, he's drinking, he's a happy, chubby cat, no danger of diabetic ketoacidosis. Okay, these are our three patients. So and we'll use this to kind of explain the different types of insulin. So scenario A, right, patient is, this is an emergency. Well, we want to get blood sugar levels down fast, so we're going to use the short-acting insulins. These work fast. They don't last long, but they work really fast. So we would use a regular insulin on him, like that. Humulin R for regular. And then once he's better, maybe we'll give him insulin every hour or something, and we'll just keep checking his blood glucose. And once it's normal, then we can switch him to an intermediate acting or a long acting insulin. So again, Humulin R. Why don't they call it, Humulin short acting? I don't know. They call it R. Here's our patient who's just been diagnosed. He or she is not vomiting or lethargic, but has ketones, appetite's down a little. So we're a little worried that maybe we should be just a tiny bit more aggressive with him. So we're going to use a short acting, or we could use an intermediate acting insulin to bring his levels down a little faster. And then we could keep him on an intermediate acting insulin for long-term control, or we might put him on a long acting insulin. So again, depending on how worried we are, we could use the same fast, the short acting insulin, or we could use one of these. These are sort of intermediate acting insulins here. In fact, we'll talk more about these in just a second here. Yeah, but these are again, the book gets a little bit confusing, but we could use one of these on him too. In fact, we could even use these long term on him. Maybe. And then again, patient C, a dog or a cat, perfectly stable. They definitely have diabetes, but they're stable. So this patient, we're not in some huge hurry. We're going to start them on either, and depending on whether they're a dog or a cat, we can either use an intermediate acting or a long acting insulin for long-term control. So let's talk about how dogs and cats are different. So in a dog, we could use either of these. We could use NPH, the trade name is Humulin N or Novolin N, or we could use this porcine insulin zinc suspension, trade name Vetslin. We could use that for a dog. That's it. Both of those in dogs, both of those will last about 12 hours. So the owner could give it at 8 in the morning, 8 at night. Sometimes this one will last 24 hours in dogs only. And so sometimes the dog may only need the injection once a day, but that's rare. In general, we don't want to give owners false hope. It's going to be usually every 12 hours. Okay, but what about cats? Well, what works in the dog will not work in the cat. So in cats, these two that work in dogs, their duration will not be 12 hours. It will not be enough. It may only be 8 or 9 hours. It has to be 12 hours. Otherwise, at the end of that 8 or 9 hours, the cat's, blood sugar is going to go sky high again. So nope, we are never going to use those in cats. In cats, we have these other two. These are definitely long-acting insulins. One is called protamine zinc insulin, or PZI. The trade name would be Prozinc. That's one trade name. And then glargine would be even better. We usually use glargine, but you can use either one in a cat. These should last 12 hours in the cat. And again, I think you're going to see most veterinarians using glargine. Now, to stay on the subject, these next two slides, they don't have anything to do with why a cat would need, glargine, but it may help you keep all these frackin' insulins separate. I am constantly having trouble keeping NPH, porcine zinc insulin, and protamine zinc insulin separate, right? Porcine zinc insulin is the acronym PZI, but it's not PZI. It's a totally different insulin. So even though I love insulins, I get really frustrated by whoever named them. So PZI and NPH, they both contain something called protamine and zinc. And in fact, NPH, remember, NPH, this is one you could use in a dog. Prozinc is one you could use in a cat. NPH stands for neutral protamine hagedorn insulin. Like, what does that mean? So what is protamine? Why do both of these have protamine in them? Protamine is actually made from fish sperm. It's a kind of protein. I don't know what's so special about it, but together with zinc and insulin, it makes these little crystals. And it's these crystals of insulin and zinc and protamine that when you get injected into your patient will slowly release insulin over 12 hours. And so the humulin has different ratios of protamine and zinc compared to Prozinc. And so Prozinc will last much longer, making it a long-acting insulin, and this one is more intermediate acting. Okay, well, what about glargine? So glargine does not have this little fish protein, and neither does that porcine insulin zinc. So these two, they don't have protamine, and here's what why I'm telling you this. You'll hear these guys referred to as members of the Lenti family. Lenti family. It's not a mafia family. Lenti is just Latin for slow. Now, I find this a little annoying because, and by slow, that we mean long duration of action. The reason it's a little annoying is this one, Vetselin, it has a long duration of action in the dog, but not the cat. But here's how this may help you, is that if they're a lentivirus, they are not a short-acting insulin, right? These are not the emergency insulins. So just that word lenti, I've seen it show up. There's some viruses called lentiviruses. Anyway, I've just found that word lenti to be a helpful word. But again, and it comes from the Latin. This word festina lenti is basically Latin for, slow and steady, or to make haste slowly. So anyway, there's a little, the story of the rabbit or the tortoise and the hare. Anyway, slow and steady, festina lenti. Anyway, just what I said. Okay. Okay, now let's talk about actually giving this medication, because it's really important that, the clients are going to be doing all the work, so we need to prepare them. There's a lot of do's and don'ts. And again, it'd be nice if we could talk to April. So anyway, again, it's every 12 hours, sub-Q injections. And they're a very different unit of measurement. This is not like anything you've seen, right? Up until now, every drug has been measured in milligrams, right? Like 100 milligrams per ml or a 500 milligram tablet. Not the case with insulin. Insulin is measured in units. I don't know what a unit is, but they use things like 40 units per ml or 100 units per ml. Like Vetsolin, if you look really closely, the Vetsolin is 40 units per ml. Now, the reason that's important is you can't just use any old syringe. You have to use what's called a U40 syringe, where each of those little increments will be 1 unit. If you want to give the patient 5 units of Vetsolin, you use a U40 syringe and you draw it up to that point right there. Others are 100 units per ml. And so they require a U100 syringe. And again, if you wanted to give, I guess we'll say that's probably 10 units. If you were giving 10 units, you would draw up to there. Now let's put them side by side so you can see the difference. The reason this is so important is that if the client or if you or I use the wrong syringe, we could underdose. Okay, that's not so bad, but we could also overdose and kill a patient. So for example, if the instructions say to give a cat 3 units of U100 insulin, if they accidentally used a U40 syringe, right? So here's 3 units on the U100. If they use this syringe and they drew it up to 3, you see they're giving almost 3 times as much of the insulin if they use the wrong syringe. And that could cause a deadly hypoglycemia. And so when we call pharmacies or if people come to pick up something from us, we need to make sure we send home the right syringe. If they are going home with Lantus, we must not send home U40 syringes. Insulins are interesting, even when they look clear. You look at these bottles, they used to have like this white powder in them. Now they don't, but there's still a suspension. The insulin is not really dissolved, so it has to be kind of resuspended. And you have to look at the kind of insulin. Some need to be gently rolled, and that just means you kind of put the bottle in your hands. You pretend this is the bottle. You just kind of roll the bottle back and forth to suspend it. But there are some, I believe, like Vetsolin, actually want you to shake the bottle, but you don't want to shake Prozinc. If you shake it, you could actually damage these little crystals. So we need to look that up. And then proper refrigeration. Where do you think, where in the refrigerator would be a good place to put some of these? So think about that, and we'll watch. This is just a nice little overview video. We'll just watch this video here. Where in the refrigerator would be a good place?
Storage of insulin is very important. It needs to be refrigerated. And in the refrigerator, there's different sections of the refrigerator that are evenly cooled. So it's really important that we don't put the insulin in the door of the refrigerator. As the door keeps opening and closing, it can kind of shift its temperatures up and down. So keep it protected from light. So on the second shelf or the bottom shelf, keep it in its box, and towards the back of the refrigerator, keep it even cool temperature throughout. Insulin handling is very, very important, as some insulins, like Prozinc, are very fragile and they need to be gently rolled, whereas Vetsolin needs to be shaken vigorously in order to get a uniform, cloudy solution. So there's 2 different types of syringes in when we're talking about handling insulin. One is the U100 syringe, which is commonly found in the human market, and then there's a U40 syringe, which is commonly found in the veterinary market, with insulin products like Vetsolin and Prozinc. The insulin syringes are labeled as a U40 or U100 based on the concentration of insulin molecules within each milliliter of solution. So a U40 syringe is actually 2 times less potent than a U100 syringe. Administration of insulin is really important, and we want to make sure that your pet is getting the correct amount of insulin. So when we do administer insulin, it is given underneath the skin, called subcutaneous, and really, really important to find a location that is comfortable for yourself as well as your pet when administering insulin. More common sites of administration are going to be between the pet's shoulder blades, on the sides of its legs, or on the sides of its rear legs as well. With any syringe, there are 3 main features. One is the barrel, the second one is the plunger, and the third is our needle. When we draw up insulin, the plunger has a top line and a black line on the syringe inside the barrel. The top line is what we judge off of, and we go on the graduation lines, equivalent to 1 unit, 2 unit, 3 unit, 4 unit, up to 5 units. So when you get your insulin out of the fridge, you want to first have your needle ready. In this case, we're using Prozinc, so it's a U40 syringe. You want to remove the plastic cap, and you also want to prime the plunger by pulling it back and pushing it all the way forth gently. You're going to grab your insulin, in this case Prozinc. You want to gently roll it between your fingers and then invert it to get ready for the syringe. You're going to uncap the syringe, place the needle into the vial, and we're going to be giving 5 units of insulin. So the graduation marks on the syringe, on the barrel, indicate 1 at each marking. So we want to go past the 1, 2, the 3, the 4, and the 5. We're going to go to 6, tap the syringe to get any air out, and then go back to 5 units. We're going to gently place the bottle down, carefully cap the syringe, and then grab our pet.
All right. Yeah. And then remember, it's all kind of artificial. The dumbest pancreas is smarter than us. So we've got to try to not mess things up. We need to make sure clients understand that we're going to give these injections with a meal. Usually we let the patient eat, and then the owner would give the insulin injection. We try not to give these injections on an empty stomach, because then glucose levels could get really low. We try to time it when glucose levels should be normally rising. It can be given subcutaneously. We don't want to give it in the muscle because that will get absorbed too quickly. We also don't want to go into a big fat pad, because then that might make absorption too slow. And we'll just watch one more little video here, just to kind of show you how to give it. And the reason we're watching this is we were going to do this in lab and practice, but you'll often be the one explaining all this to owners. And so it's good for you to start developing your own style on how you would explain it.
To keep your diabetic pet happy and healthy, giving insulin injections will become an important part of your daily routine. Insulin administration is an important piece of your pet's diabetes treatment and is just another way to show how much you care. Initially, giving your pet an insulin injection may seem intimidating or overwhelming, but over time, the process will become just another part of your day. This short video will walk you through each step of the administration process. Your veterinary team will be able to give you advice specific to your pet's needs. Let's get started. Unless otherwise directed by your veterinarian, feed your pet before giving insulin. Take your pet's insulin out of the refrigerator and prepare it according to your veterinarian's instructions. Some types of insulin should be rolled between your hands to gently mix it, while another type must be shaken until it appears milky. Clean the rubber stopper by wiping it with rubbing alcohol. It's very important to make sure you're giving the correct amount of insulin with the correct syringe. Your veterinarian will let you know how many units of insulin your pet should receive and which type of syringe to use. While many people aren't comfortable around needles and syringes, remember that insulin needles are very small and very sharp, so your pet will barely feel the injection. Never change your pet's insulin dose or the type of syringe without speaking with your veterinary team. To prepare the syringe, first remove the cap. Draw up air into the syringe to the number of units your pet will receive. We will use 5 units as an example. Inject the air into the insulin bottle. This helps keep the pressure in the bottle stable over time. Turn the insulin bottle upside down, making sure the tip of the needle is covered by liquid. This ensures that once you start pulling back on the plunger, you're drawing up liquid, not just air. Draw up the prescribed amount of insulin, in our case, 5 units. Now, it's time to find our patient and give them some TLC. You may need help from another person to keep your pet still, but some will stand quietly if distracted with low-carbohydrate treats. Find a good location for the injection that works for you and your pet. Many pets tolerate injections well when given about 1 to 2 inches from the middle of the back, near the shoulder blade, or the hip bone. Be sure to alternate the location each time to avoid soreness. Hold the syringe in your dominant hand. For safety and to keep from losing any of your pet's dose, do not place your finger on the plunger until the needle is in the skin. Using your other hand, pinch a fold of skin into a tent and gently insert the needle into the center of the fold. Once the needle is through the skin, draw back the plunger. If you see blood enter the syringe, you're in a blood vessel. Pull the needle out and try another location. If you do not see blood enter the syringe, gently push the plunger all the way down until the full dose has been given. Remove the needle from the skin. Run your hand over the injection site to feel for moisture. This could mean the insulin wasn't correctly injected under the skin. Call your veterinarian if this occurs. Safely dispose of the needle and syringe in a closed sharps container. Talk to your veterinarian if you need one. Now celebrate, you did it. Diabetes management is a journey filled with ups and downs, and your veterinary team will be beside you to make your pet's future as bright as it can be.
Yeah. All right. All right. And like they mentioned, they were feeding some snacks while he ate, but in general, we have to often avoid snacks. Better to have the patient eating. They can, while they're eating, you can have the client can give them a poke. It often requires 2 people. In cats, remember, remission is possible in cats. So the weight loss and exercise may help. If they lose weight, then they may be able to go into remission. There are other drugs that have been discussed, but they don't work very well. So there's a drug that people take called glipizide. And what it does is it has nothing to do with, it's not insulin, but it makes the beta cells secrete more insulin, right? So it only works if there's some pancreatic function left. So it sounds good, right? It's just going to make use of the pancreas. The problem is, and I don't know why, but the problem is there's studies that show that it will actually accelerate the loss of those beta cells. It'll make things worse in the long run, and that'll make the glipizide ineffective and just make everything worse. So insulin is recommended, glipizide is not. And then this is important. There are drugs to avoid. There are certain drugs to avoid. And the main one would be the glucocorticoids. Things like prednisone, dexamethasone, triamcinolone. You recall when we learned these are generally used for controlling inflammation. A patient with itchy skin. At high doses, we can use it to suppress the immune system, but mostly these are used for flea allergies, airborne allergies, sometimes for food allergies, things like that. What happens is these glucocorticoids, these are hormones. They're very, very tiny. They go into cells and they will interfere with the action of insulin. So you could have a patient who's well controlled on insulin and you start giving them prednisone, and now suddenly their blood sugar levels are sky high again. Because remember, that's what glucocorticoids do. They help release glucose. They cause gluconeogenesis. The liver releases glucose, proteins and fats. Well, I guess proteins can be used, I guess, to make glucose. So that's what glucocorticoids do. So it makes sense that we would not want to give it to a patient with glucose problems. There are other drugs to avoid, but glucocorticoids would be the main one. And as we mentioned, your role, this is big news. It can be life-changing news when a client learns that their beloved dog or cat has diabetes, and we want to try to help them through it. So the many things, and this is very time-consuming too, and so we don't want to be in a hurry. And so it's really great. I can help the client, but it's really great if you can help the client too. So going over, the treatment and handling the bottle, the rechecks. These rechecks are a little different from the methimazole and the levothyroxine. We don't just do one glucose test. We do what's called a curve. We take little blood samples over the course of the day, and then we watch what the blood glucose level was at 8 a.m. and then we give the insulin, and then we watch it every hour or 2 hours. The glucose should go down, 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 and then when the insulin wears off, the blood glucose starts to go back up, up, up again until there's time for their next dose. And this is something owners can do at home if they're willing to. It's actually a lot more accurate if they can do it at home. And then again, that's something else. You can teach them how to get a blood sample from the buccal mucosa, or sometimes from the pad of their foot or the tip of their ear, and they can do their own curve. Talking to them about what they can do in cats to achieve remission, possibly. There's so many things. There are cat litters that will change color if there's ketones. You can talk to them about signs of improvement, signs of worsening, like in dogs, the cataracts, things like that. The owner may think their pet is itchy and they'll put a hydrocortisone cream on them. No, that could mess up. That's a glucocorticoid that could interfere with insulin. So the itchy diabetic pet is a challenge. All right, we're going to look at two more endocrine diseases, and then we'll take another break. And when we come back, then we'll talk about reproduction. But let's finish up with a totally different gland. This is the adrenal gland. This little gland sits on your kidney. It's actually two different glands in one, but we only care today about the outer gland. That's called the adrenal cortex. And we learned about these hormones before. One of the hormones is glucocorticoids, right? We're talking about them. This is what all the drugs like prednisone and dexamethasone are based on. And the other hormone they make are what are called mineralocorticoids, and the main one would be aldosterone. And we also learned about that when we learned about the renal system and the cardiovascular system. So let's review what they do. Well, first, let's kind of review the whole process. So these are both stress hormones. When your mind detects some sort of stress, maybe a job interview, maybe you're being chased by a bear or something, the hypothalamus releases corticotropin releasing hormone. Remember, tropin, well, we'll talk, yeah. So tropin means to have an affinity for. And so corticotropin means it has some sort of an affinity for the cortex, meaning the adrenal cortex. But it gets released, and it's going to stimulate the pituitary gland to release this hormone called ACTH. That stands for adrenocorticotropin hormone. So again, it's a hormone that has a affinity, tropin, for the adrenal cortex, adrenocortico. So it's going to go to the adrenal gland, and it's going to stimulate the adrenal gland, the cortex of it, to release both cortisol and aldosterone. Aldosterone is not shown here, but the cortisol is. And then it shows some of the things that are going to happen. Blood sugar is going to be increased. Blood pressure will be increased. I got a better slide than that. The point is, together, aldosterone and cortisol, they help you in stressful situations like that. So what do glucocorticoids do? As we said a moment ago, they're named for their effect on blood glucose levels. They are going to break down proteins and lipids. They can be converted to glucose in the liver. They're also going to stimulate the liver to release blood glucose. I don't know how this, well, some things that help with stress are a little weird. It's anti-inflammatory, it stabilizes cell membranes, that makes sense. Suppressing the immune system, I don't really see how that helps me deal with stress, but it's something they do. And then, like we said, aldosterone, mineralocorticoid, the mineral that we're talking about is in particular sodium and potassium. And so aldosterone is the principal mineralocorticoid hormone. It targets the kidney and causes the reabsorption of sodium, and water will follow via osmosis. To keep things in balance, when aldosterone stimulates the reabsorption of sodium, the body has to get rid of an electrolyte in exchange, kind of like a prisoner exchange. And so potassium is secreted. So, some sodium ions are reabsorbed and some potassium ions are secreted. But the point is, when sodium gets reabsorbed, water follows, it expands your blood volume and increases your blood pressure, so you can run away from this bear while you're on fire. Okay? So that's these two hormones. Well, here's a disease where you have excessively high levels of glucocorticoids, excessively high levels of cortisol. This disease is called hyperadrenocorticism. It's also named after Dr. Harvey Cushing, so it's called Cushing's disease. And these are some classic signs here. You can see them on both dogs. The dog has lost muscle mass, and so his belly just kind of is hanging there. It's caused all this hair loss. Those are some of the signs we see. There's some skin problems you might see as well. This disease is caused by a tumor. Either a tumor of the pituitary gland is making excessive ACTH that we just talked about, or the tumor is on the adrenal gland and it's making excessive cortisol. Again, here's this catabolic steroid, right? Catabolic means it breaks things down. So we have these excessive levels of a catabolic steroid affecting almost every cell in the body. So we mentioned some of the clinical signs: hair loss, the belly, but that's not why the client brought him or her in. They might just think these are normal aging changes. The main reason clients bring these patients in is because of polyuria. These patients, it's like they're addicted to water. They're polydipsic and polyuric. They're also polyphagic, but they are drinking so much water and they are peeing so much that they are now peeing in the house. This dog that was, and by the way, this is mostly just in dogs. You might see it in a cat. You could see this in a cat. You're mostly going to see it in middle-aged dogs and older dogs. These dogs that were normally well house trained are now peeing in the house. They can't hold it because they are just drinking so much. It's something the cortisol is doing to them. And we'll learn about diagnosing it more next year. So the goals of treatment, again, are to, we may not be able to get rid of that belly, but we should be able to control the urinating, the drinking, the eating, maybe get some of that hair to grow back. Those would be some of our goals. And there's actually several different treatments, and it depends on whether the tumor is on the pituitary gland or the adrenal gland. But there is one drug that can be used to treat either kind, and that's called trilostane. The trade name is Veterinary, and it does not cure hyperadrenocorticism. All it will do, it's kind of like, remember how methimazole blocked the production of T4 and T3? Well, this is the same sort of thing. It's going to block production of cortisol. And so that's how it works. The opposite disease is called hypoadrenocorticism. It has its own name after Dr. Addison, and that's called Addison's disease. President Kennedy had this disease, and so he was on lifelong treatment for it. Here the problem is I'm pointing to the wrong gland. The adrenal glands start to atrophy, and so they're making inadequate amounts of glucocorticoids and mineralocorticoids. Primarily affects dogs, and the clinical signs are a little strange because they can vary from case to case. One dog will look like they'll have vomiting and diarrhea, so you'll think it's a gastrointestinal disease. Some dogs will have all of their liver values will be abnormal. Another animal, all of their kidney values will be abnormal. But they don't have kidney problems or liver problems or gastrointestinal problems. It's all hypoadrenocorticism. And that's why this disease is called the great pretender, because it can look like a lot of other diseases. And the clinical signs are a little hard to explain. We see things like anorexia, polyuria, polydipsia, weakness, vomiting, diarrhea. They're not really specific signs. It's not like the cat with the plantigrade stance, you know what I mean? But we can try to tie them in with this lack of stress hormone. So for example, if you lack cortisol, well, then you have a reduced ability to mobilize glucose and fat. So you're probably going to be really tired with this constant kind of low blood sugar feeling. The lack of aldosterone means you can't raise your blood pressure when you need to, and then that makes you also tired and collapse. But again, these signs are kind of hard to explain. So like HAC stands for hyperadrenocorticism. We'll discuss it more next year. Today we're focusing just on the actual drug. So there's no cure for it. We just have to supplement these hormones, and there's a couple different ways to do it. One is there's an injection, I don't know how to say this, desoxycorticosteroid pivalate. We call that DOCP for short. One of the trade names is Percortin. So Percortin, and this is a mineralocorticoid. It's kind of an odd one because it's usually given like every 25 days. That's the short answer. The long answer is we can sometimes make it last 28 days, but some of these dogs, you have to schedule a recheck every 25 days, and then they get their Percortin injection. And then that applies the mineralocorticoid, but for the glucocorticoid, they still need something. And so these pets may take really tiny amounts of prednisone every day, what's called the physiologic dose. So it's a really tiny amount. It's much lower than they would take if they had, itching. Alternatively, there is a pill called fludrocortisone that contains a mineralocorticoid and a glucocorticoid. So again, it's like it contains aldosterone and cortisol. And that's just something they would take every day for the rest of their life. Okay. All right. I'll make a Kahoot number 2. It may not have that up till Thursday, but I'll try to get it up tomorrow. Again, it'll be very basic, a very basic little Kahoot. But it's kind of, I know it's kind of a useful way to just check your basic understanding. All right, that's the end of part 2, and then I'll see you in part 3 where we talk about endocrine disorders.